Next, it's a pleasure to welcome back our previous moderator, Bronson TuckerEdmonds, who is Assistant Dean for Faculty Affairs, Professional Development, and Diversity. And she is also an Associate Professor of Obstetrics and Gynecology and Clinical Pediatrics at Indiana University School of Medicine. Dr. TuckerEdmonds, you ready?
Thank you so much for the opportunity to present and for the invitation. I'm going to talk to you guys today about maternal mortality and medical misogynoir. So obviously we're here to discuss our nation's maternal mortality crisis. We discussed at length that the US is one of the most dangerous industrialized nations to give birth in, and that for Black women in particular, who are experiencing 3 to 4 times the rate of maternal mortality compared to white women, that the risk of dying in or after pregnancy is rivaling that of low income and developing nations. Next slide. To understand Black maternal health inequities, we have worked by Geronimus and others on sort of weathering that's helped us to develop a framework as to how structural and systemic inequity is experienced and embodied as chronic stress and accumulates over the life's course, even across generations, to create physiologic disruptions that increase the allostatic load and accelerate cellular aging and disease risk in Black women, ultimately resulting in inequitable health outcomes. So they've covered a lot of ground with this particular sort of conceptual framework. But as I was trying to prepare like a 10-minute talk, I wasn't even sure where to begin to kind of unpack the complexity of the problems that are facing us as we contend with Black maternal mortality. But I decided to, and I guess this is the tendency, this is what I tend to do, is to look backward in order to help us look forward. So I started here, if you could advance for the arrow and point to the, I started here at the beginning with the current and historical dominant cultural systems and ideologies and resource allocation, really trying to connect some dots between how these issues inform present day implicit and explicit biases and obstetric racism. Next slide. My mind immediately went to Serena Williams, who has been mentioned in today's discussions. 2017, following the birth of her daughter, she suffered a postpartum pulmonary embolism. And in the Vogue interview, she described being dismissed as confused, even as she told the healthcare providers exactly what her diagnosis was and exactly the diagnostic treatment, testing and treatment that she needed. People at the time, and I know this is for those of folks in this audience, can recall that people were really dumbfounded and genuinely perplexed as to how the most famous tennis player in the world could be dismissed and diminished, disbelieved in this moment. And there was sort of a resounding question, if fame and fortune can't protect you, what can? Next slide. And so to understand why fame and fortune won't save you, you have to understand how distinctively bias operates against Black women. To understand, as we've talked about a couple of times today, why college-educated Black women die at higher rates from pregnancy-related causes than white women who don't finish high school, you have to understand misogynoir. And the term has been utilized a couple of times today. It's a term that's coined by Black feminist scholar Moya Bailey to describe a specifically anti-Black racist form of misogyny that Black women experience as stereotypes, violence, oppression, and dehumanization, sort of unique to Black women's bodies, experiences, lives, and histories. Serena Williams has really been victim to misogynoir since she stepped into the public eye, even as a teenager, as a child. And you'll notice in these unbecoming depictions, immediately sort of this portrayal, both as sort of the angry Black woman, but also the hypermasculine, manly renderings, or conversely, you also see some of these hypersexual kind of catsuit depictions. Next slide. This particular form of violence and dehumanization against Black women has its roots, like most forms of anti-Black racism in our nation's history, in our history of chattel slavery. So Deidre Cooper Owens writes about this the legal doctrine of partus sequitur dentrum, which was adopted in Virginia in 1662. And that's what stipulated that the status of the child would follow that of the mother, meaning that he'd be born into slavery. And so once enslavement becomes an inheritable status, then Black childbearing becomes central to the enterprise of slavery. And at that point, then society, particularly once it's outlawed, but even before so, society comes to monetize and commodify and exploit Black women's labor. And really, you can see that on three different fronts: their physical labor, their reproductive labor, and their emotional labor. Next slide. Here we are. So white kind of racist ideology is always trying to square itself with sort of these deeply held kind of virtues around reason and enlightenment, morality. And so these narratives then become crafted, right, as justifications. And they emerge then as archetypes and ideologies that really essentialize Black women as existing for the function that they serve, right? So we take just these three examples, and there have been others written. Patricia Hills Collins does great work in this space, but let's just take these three examples. The mammy, for example, is submissive. She exists for emotional labor. She puts aside her own needs in service of whites' caretaking and domestic servitude. And in more contemporary portrayals, she serves as sort of the Black best friend, there to offer, moral support, but two-dimensional in her own right. The Jezebel, right, is sexy, and so she exists for reproductive labor. She meets the sexual and economic interests of white men of the day, but she had to be a seductress, hypersexual, born to breed. And then if you kind of fast forward into more contemporary renderings, this would give rise to sort of welfare queen tropes. As we sort of round that out, we think about the sapphire, who's sassy on the one hand, but actually aggressive when we think about her existing for physical labor, right? Because this is the hypermasculine archetype or trope. It's the depiction as being emasculating and aggressive. And so she becomes sort of the outspoken, strong Black woman, or the loud and belligerent, angry Black woman, emasculating Black men, threatening white men and women. Next slide. And once you start to look for these patterns sort of in our media, in public spaces and public discourse, you start to see these patterns of hypermasculinization and hypersexualization everywhere you look, from manly Michelle, next slide, to emasculating or seductive Megan, next slide. Obstetric racism is in fact rooted in these two-dimensional depictions and sort of dehumanizing, reductive ideologies that deny Black women the full range of experience of human emotion, of human suffering, of human pain, even of human joy, which has come up several times today. That J. Marion Sims, experimented on enslaved Black women's bodies to become the father of modern gynecology reminds us, and I say us to myself as an obstetrician gynecologist, that our profession's origin story arises from the dehumanization of Black women. Next slide. And so the cost of this has been sort of talked about in a number of different terms today. I term it as a form of medical misogynoir, a system of care that Sturgeson actually sort of identified in some work as both neglectful and judgmental. This sort of plays out. There's a scholar, Tamara Lewis, who has tweeted about cumulative deprioritization in that space of, whose bell gets answered, who gets sent to, for their CT, or, how just cumulative bit by bit deprioritization of folks of color and the level of avoidance oftentimes and ignoring the needs that people have already spoken to. And then there are the issues of judgment. Judgments are made about Black pregnant people's fitness to parent, which then result in disparate social work consultation, child protective service, and criminal legal referrals, the validity of their pain complaints, which then result in inadequate pain management, in and after delivery, and their respectability. And that's based on a range of issues from age, marital status, appearance, all resulting in demeaning behaviors and insensitive comments that were described in some of Sturgeson's work around, their baby daddies, their children's Black sounding names, things that are just par for the course on labor deliveries across the nation. Altman and colleagues did work that would also report that women of color express that these judgmental attitudes, that the power dynamics and the interpersonal racism that they were experiencing and encountering in these spaces often influenced how healthcare providers chose to share information with them. In turn, as people have talked today about autonomy and decision-making, these experiences then have meaningful impacts on their ability to control decision-making. And so with these dynamics at play, I study shared decision-making as a model of care that, if deployed appropriately, may have the possibility of mitigating some aspects of maternal health inequities by humanizing, elevating, and centering Black birthing people. When I speak in terms of shared decision-making, I speak in terms of shared power. And for me, that means that the clinical encounter is structured around shared priorities, that we create shared agendas, that we invite patients to tell us what their must-discuss items are to ensure that their concerns are addressed, that we manage expectations about desired and most probable outcomes, depending on their expressed goals of care, that we attend to what patients want, eliciting their preferences, their values, aligning them with the treatment plan, that we acknowledge patients' expertise in their lived experience, and that we engage in bi-directional exchanges of information and expertise. And then finally, that we take on shared responsibility in partnering to make decisions together. Notably, shared decision-making only attends to that sort of interpersonal aspect, that one level as we talk about how racism operates. So it only attends to the sort of interpersonal aspects of implicit bias and obstetric racism. And so these efforts then have to be paired with systemic and structural remedies that are intended to really, create and affect meaningful and transformational change, to develop more patient-centered models of care. It's come up already today that we'll need to integrate frameworks for trauma-informed care, for reproductive justice, and that has to happen in the manner in which we deliver sexual and reproductive health care across the life course. Next slide. And within the realm of obstetrics, we'll need to integrate medical and midwifery models of care to ensure that Black women are afforded the full spectrum of supports that are needed. In 2019, I had the honor of serving on the consensus, the Academies consensus study committee that produced the report, Birth Settings in America, Outcomes, Quality, Access, and Choice. And during those deliberations, we spent time really wrestling with how to attend to this dual reality. But on the one hand, it's really clear, we've heard an abundance of data today that supports the notion that woman-centered midwifery models can actually mitigate the harms and the disrespect experienced and directed toward Black women. And at the same time, where we started with Geronimus, we have to contend with the fact that the effects of systemic racism and weathering across generations have embodied physiologic consequences that render Black women more vulnerable to medical and obstetrical morbidity, that may indeed be more safely managed by medical teams. And so with the current debates, my sometimes frustration is that they seem to be focused on whether Black women would fare better, birthing in the community or birthing in hospitals. My hope is that we could really move beyond sort of the either or divide to imagine and forge more integrative models of care, because I fully believe that Black women are deserving of both and. Next slide. And so I'll close with a quote by the Combahee River Collective, a Black feminist movement named after the Union Army raid that Harriet Tubman led in 1863 to liberate 750 enslaved people in South Carolina. The quote reads, "If Black women were free, it would mean that everyone else would have to be free, since our freedom would necessitate the destruction of all systems of oppression." Thank you for your time and attention.